want to just give a brief update on restraints and sedations as it's being looked at very closely, and the DOH continues to find fallouts, and we are not where we need to be as far as compliance. So thanks for watching. Like and subscribe. So for sedations, you got to order the sedation. Reason being, that order that's checked there triggers the nursing documentation that is required for a sedation. You also need to order procedural sedation, the bottom one for respiratory therapies charting. We've made that, so that will be now a reflex order that gets checked once you order the ED sedation. When you order your meds, propofol deserves some specific note because what was happening is, say you would order propofol for a sedation, you'd have to put in an amount in milligrams, and say you put in 100 milligrams, and then ended up giving 150. That was considered a fallout because the order didn't match the charting. So now what happens if you order IV push propofol? It'll come up with this C dose instructions, and then with the dose instruction of lowest dose to be achieved, or lowest dose to be administered for adequate sedation, and it's to be given by the provider. And then, so once that's done, when you're actually documenting your sedation in your procedures tab, best practice will be to, as you can see, I've got the window box opened for propofol here to put exactly how much you gave. In this case, 40 milligrams twice, totaling 80 milligrams. So that's it. That's it for sedations. Those are relatively easy. Now we're going to get into restraints versus nonviolent. Nonviolent restraints need to be renewed every 24 hours. And you got to make sure that the type, for example, all extremities, matches the documentation and what's going on in real life. If you order 2 points and the nurse documents 4 or vice versa, that's a fallout. Here is the restraint order with all the necessary boxes that you have to fill in now. And those are pretty easy. But again, just a reminder that all extremities has to match the nursing documentation. For chemical restraint, you need to order the meds prior to medication administration. And in this case, if you order, say, ketamine, it's going to reflex the chemical restraint order. Or if you order chemical restraints, you can order the ketamine through there. Just make sure that both the medication and the chemical restraints get ordered. Make sure the nurse knows that you're chemically restraining a patient, and then the face-to-face has to be done after, but within 60 minutes of the medication administration. And that's caused some fallouts where, for example, if we were waiting for police to come and hold down the patient so you could give them the meds, and then the face-to-face was documented before that happened, that's a fallout. Justification for continued restraints is not applicable for chemical restraints, as it's a one-time order. Remember that if you order chemical restraints and then have to order more meds in 10 minutes, that's a whole new episode of restraint with a new face-to-face and a new order. Like with all the restraint orders now, there's all these boxes you have to fill in. Again, you can put not applicable for earliest removal. For chemical restraints, it's a one-time order. Your face-to-face should be violent chemical with physical hold if you're just putting them in chemical restraints. If you're physically restraining them as well, it's the one right above that if they're going into 4-point. Restraint types, chemical, it's got to match the documentation, and then all this, feeling like I'm in Meditech, and then all the stuff below that you're used to doing now. Again, you need to continue or terminate violent or chemical restraint. For chemical restraint only, that can be not applicable. Violent restraints, a reminder that you renew them every 4 hours for adults, Q2 hours for ages 9 through 17, and every hour for ages 8 and below. You need a fresh face-to-face with each renewal, again, after the time is up, but before 60 minutes is up. If you discontinue the restraints and then reapply them, that's a whole new order, a whole new episode, whole new face-to-face. And ensure the restraint type matches documentation and real life. Been through this already. For this one, you do have to document earliest removal determinants. And then when you renew them, again, it's a renew over here on the right, not a full new order. So, for this one being done at 5 a.m., your renewal is going to be done at 9 a.m. with a new face-to-face from 9:01 to 9:59. Couple pitfalls we've seen lately: if a nurse places a patient in violent restraint when they're chemically restrained and doesn't communicate that, that's a fallout. So go look at your patient, see if they're in violent restraints, and if so, order them or talk with the nurse about do they really need them. If you're waiting to give medication until necessary support is in place, for example, police, do not document your face-to-face until after the meds are given. Make sure to renew your violent restraints at appropriate timeframes. Best practice, I think, would be to put the renewal time in the tracker comments. And if you're still going to be on shift, then set an alarm on your phone and make sure it's very clear during sign out if you're not still going to be on shift. If a restraint type is changed, say you're going from 2-point to 4-point locked restraints, you need a new order, new face-to-face, etc. Thank you very much.